Fine.
Okay, we are going live. Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the chat box and they'll be addressed.
Good morning, everyone. We apologize for the delay. We're having some technical difficulties. I'm honored to introduce our mentor for today, Dr. Nadra Khan. Dr. Khan is an internist at Anne Arundel Medical Center in Annapolis, Maryland. She is passionate about giving back to her community and works on many humanitarian projects in the DC, Maryland, and Virginia areas. Dr. Khan is also TeleShadowing's Maryland Medical Director, and we would like to thank Dr. Khan for dedicating her time to us. Thank you.
Thank you. Thank you for the nice introduction. I was told that I should tell something about myself, and then I can describe a case to you for a teaching purpose. So as a physician, I've been asked this many times, what was the reason choosing medicine as a profession? So now you have to think that at the time I graduated in 1983 from Allama Iqbal Medical College, Lahore in Pakistan, we did not have that many resources available like you have. So you have internet access, you can chat with people who are in this profession, you get information from different resources, but I did not have that privilege. So basically my father guided me. He told me that it's a good profession and I should go into it. Basically, I went into medicine not knowing a lot about medicine. So I learned about medicine as I was in the profession and made my decision based upon what I like and what I don't like. Having said that, I think it's a really good profession and it is rewarding, but it involves a lot of hard work and it involves dedication and commitment to lifelong learning. So if you want to join medical profession, so you should be prepared for all those things. Next slide. Okay, so after I graduated from Allama Iqbal Medical College in 1983, I actually worked in Pakistan for many years. So from 1983 to 1997, I was in Pakistan. In Pakistan, you have to basically do a training called house job, and I chose to work in surgery. Like many people, I was fascinated with surgery and I thought I should go into surgery. So I spent 6 months in surgery, and what I learned was that that is not for me. It involves standing for a long time to do surgeries. You have to come to hospital very early, go late. So, and I also discovered that my hands are not that steady. So in the process, I learned that I should look for some other specialty for myself instead of surgery. So next thing I explored was pediatrics. So I like children. I thought I would like it, but handling little kids at that point in time, I was young myself, and I found that stressful. Some people like to treat kids, but I felt that it wasn't for me. And for 6 months training in pediatrics, after that, actually, I was in Pakistan, the system is this way that at that time, at least, that after 1 year of training, you become a medical officer. And I became a medical officer in CCU, which is medicine. And actually, I had not worked in medicine before that. So I did learn a little bit of cardiology, but I got married at that time. I had family life and it seems too stressful for me. And that is how I landed into pathology. And that is what I made my career when I was in Pakistan. So, and I thought that I will pursue pathology as a career choice. So I will tell you a little bit of my experience in pathology. So basically, pathology is a field where you're still in touch with medicine, but you're not seeing the patients. You're helping the patients. You're doing their tests. The diagnosis depends upon what you do in pathology correctly. And you help them, but you are not there interacting with them or holding their hand or talking to them. So when I was in pathology, that was, I was trained at Fatima Jinnah Medical University in Lahore, which is a teaching institution. So in Pakistan, you require this, that you have to have a certain year of training before you can go into a postgraduate program. In pathology, we rotated in 4 sections, which is histopathology. So what histopathology is, and if somebody wants to know about, is that you basically, whatever is removed from during the surgery, like, for example, if a woman has a hysterectomy and the uterus is removed, then you first examine it, look at it, and see if there is anything that you can see grossly. And if you don't find any abnormality there, then you basically cut in pieces in a certain way and process the specimen and look under the microscope on the slide and see what it is. Now, this field has advanced a lot, and a lot of new techniques have been involved, particularly in diagnosis of cancer. So that is beyond the scope of this lecture. And the second field that I rotated in, second section that I rotated was hematology, which is the diagnosis of blood disorders. And so basically it involves looking at the bone marrows and looking at checking for hemoglobin and white cell count. So basically that is another field of pathology. And some people opt to go for that also because pathology has its own subspecialties. We also rotated in chemical pathology, which involves testing for chemicals in blood, like creatinine, which is to tell you about kidney function, glucose, electrolytes, so those kind of things. And the final section we had was microbiology, where you test and see what infections are caused by different bacteria. And it also involves testing blood and body fluids and seeing where the infection is coming from. So basically, that is what we were doing over there. And in addition to that, we taught medical students. And so I really actually liked the job, although I was, like when you're working in pathology, you might be seeing a slide where there is cancer, right? But since you're not seeing the patient, you may not go through that stress because you don't have to convey that information to the patient. All you have to do is to write diagnosis. So if somehow you are not the person who like to have a direct contact for the patient, so then this is some field that you can consider. Basically, after doing my training, I did postgraduate training in MPhil microbiology, and that involved studying for 2 years and doing some research work. And by the time I finished and I was ready to go into practice and apply for a job of assistant professor in pathology, my career path changed again, and I came to USA. In our immigration was processed in 2006, and we finally moved in 2007 to USA. And so that is where I had to change my career again. Next slide. Okay, so again, like I was telling you, that we did not have that many resources in Pakistan. So I did not know which specialty is good to work in USA. I learned from somebody that pathology is something where you cannot find job and it's not a good profession in USA, unlike Pakistan. So I listened to that person. I said, okay, I'll try medicine. So I was kind of a little flexible too, if you can see. Oh, so I landed into a residency program in Chicago at Ravenswood Hospital Medical Center. And that was a 1-year program called Medicine Preliminary. Now, Medicine Preliminary program is something where you can, if you're indecisive, you can join and see what medicine is like. Or it is also a requirement for certain subspecialty of medicine. So for me, I had to see whether I can, after so many years in pathology, can I actually do medicine? And when I was doing that, I decided that I will continue in medicine. I want to emphasize one thing more. What made me make this decision was that in USA, residency programs are very well designed. You never feel that you are asked to do something which you are not trained for. You have adequate supervision and support available, so that this made me feel comfortable going into internal medicine, because I felt that if I don't know anything, I can always ask my seniors. I can ask subspecialists to help me out in whatever I don't know. And I also learned that it's okay to not remember everything. I can also go to the resources on internet, like UpToDate, and update myself. And so I can treat my patient in the best possible way. So this is what I learned after coming to USA and joining this residency program. And it was, I should say, a good experience for me. And after that, I continued in medicine. After finishing my training, I moved to Las Vegas to practice. And I worked in two different ways. One was a traditional practice setting, which was practice more in older days. It is still practice, but I think we are changing more to more between split in medicine and hospital, and I will describe it to you what it is. So I worked in traditional medicine, and what traditional medicine is that you basically work in a clinic. You have a clinic where you see patient half of the day, then you go to hospital, you see patients there, and if your patients get better from the hospital and they are not ready to go home and go to rehab center, you go and see them in the rehab center. And for example, if they don't get better this much that they can live independently and have to go to nursing home, you follow them there. So basically you follow your patient from outpatient clinic to hospital to rehab to nursing home, wherever they are, you are there for them. That is the good part about traditional medicine. But the bad part is that since you are going to different places, it involves traveling. You may have to go from one hospital to another. So you might have one patient in one and the second in other, and then you go to rehab center or your clinic. So it's kind of, you waste a lot of time on the road to see those patients. So when I was in Las Vegas, this hospital medicine concept was coming up and a group was formed over there, and I thought I should explore this. At that time, not that many people were working as hospitalists. The concept was relatively new. I mean, I'm talking about it's somewhere 2001 and 2002. So to me, it somehow attracted, because as a hospitalist, you don't have to go to multiple places. You just go to one hospital. You just see patients in the hospital, not in the clinic. So you can just stay focused or make yourself better in providing care in the hospital setting. There are hospitalists who work in the rehab setting only, and there are hospitalists who work in the hospital setting only. The other good part of hospitalist career is that you don't have calls, which means once you leave your work, you're done and your colleague will take over the work. Some hospitalists would like to work daytime, I should say majority. And that basically means you come and see your patients morning until leave later in the evening, and your nighttime colleague take over. So I like that. And I thought that if I am staying in medicine, I should probably do hospital medicine. In the meantime, I had this opportunity to go to Saudi Arabia. So you must have seen I'm quite an explorer. So that was in a tertiary care center. So I will just tell you a little bit about this in case anybody who is thinking ever working in Middle East, so you would have some idea. So Saudi Arabia, actually, I went there because there was a tertiary care center in Riyadh called King Fahd Medical City, which is one of the biggest hospital in Saudi Arabia. And so my attraction was that I had not worked in a tertiary care center. So I wanted to get that experience and see how it is like. So the setup over there was different from USA in this way that over there was division of work this way, that there was a consultant in our team, associate consultant, assistant consultant, and the resident. So the 4-people team. I was the senior most consultant. I have an associate who was also board certified, assistant consultant who was coming from mostly they were coming from India, Pakistan with a postgraduate degree in medicine like FCPS, and the resident was a Saudi, which we all have to train. So here my work was different. I wasn't writing notes like I do in USA. I wasn't doing a lot of things because the team was helping me. My job was more like a supervision, doing rounds with them. And also I was involved in multiple different activities like planning, administrative work for the medical department. And I had to screen patients who can come to for treatment to our hospital, and advise patients or the doctor who's taking care of the patient that, you know, your condition can be treated over there, and this is the modification you should make, or you can come as outpatient in our facility, not as an inpatient. And in addition to that, we also had different committees. So I worked as a head of one of the committees, and we did some research work also. So it was probably, if you work in a tertiary care hospital in USA, it would be similar, except that, you know, your work balance might be different. Other thing about Saudi Arabia was that you had a lot of vacations, much more than in USA. And people were more laid back, so it's a little less stressful job. And because there are not that many taxes, so you save more money. So those are the good points about Saudi Arabia. But of course, they have their own custom, and you have to follow that. And if you don't like it, you may not like to live in that country. So that is about Saudi Arabia, in case ever anybody who's listening in the audience likes to go over there. But my advice is, if you want to go over there, I think, go to a bigger city and work in a bigger hospital, because bigger hospitals, they have mostly doctors who are trained in US and Canada, and you would not face problem because your colleagues are similarly trained and you can relate with them. Other thing about Saudi Arabia, that what I was actually working in my department, everybody was a male physician except me. And somehow people feel that maybe women are treated badly, but I was treated in a very respectful manner, and I never feel uncomfortable over there. And so this is a misconception. I had a really good experience. And after that, as my children were growing up, I have 4 kids, and my children were going to join University of Maryland. That is where I landed up, in Maryland, and I have stayed in Maryland since then, which is like 2006 or 2007, and I have worked as a hospitalist. And I already described you what hospitalist life is like that. I chose to be a nighttime hospitalist, and for me, the reason was that I work 3 nights and I get 4 days off. So although the work is hard, but I like this part, that I have 4 days where I can do whatever I want to do, and I don't have to think about the hospital. Other thing is that when you're working as a nighttime physician, so you don't have that many subspecialists available. So you have to be confident in that manner that you won't call subspecialists unnecessarily. You know, you should know where exactly they're needed, because of course, they're on call and they have to come next day to work. So you don't want to wake them unnecessarily. So you should have this much of confidence. And also, you should not compromise patient care this way, that you don't call them and something happens to the patient. So keep a balance. Next slide. Okay. So this brings us to our case. I hope you got some information by my description of career about pathology, medicine, and hospital medicine. So the case that I'm describing here is something we see commonly as hospitalists. And this is the patient who passed out in a parking lot. 60 years old male, he was brought to ER after he passed out in the parking lot. And you must have witnessed that people can pass out at home, in parking lot, in buses, or in shopping malls, and then ambulance is called and they are brought to the hospital. And so this particular patient, when the doctor saw him, he learned that he has hypertension, and he takes 4 medicines to control his blood pressure. And at the time he presented, he looked fine. he was talking normally and his exam was normal. He did not detect anything abnormal except that the blood pressure was low. So they gave him IV fluids in the ER and they did some blood tests to see if they detect any abnormality on blood tests. And the blood test also included troponin. Troponin is a blood test to detect a heart-related problem, particularly heart attacks. And this is something you do on all syncope patients. EKG is also done anybody who is coming when they pass out to detect any abnormality. This patient also had a head CT, and this is something you don't do on everybody who pass out. So EKG and blood tests are done on everybody, but not the CAT scan. Some people you might do it if you think any abnormality could be in the brain, but not each and every patient. In this particular case, doctor felt that this patient is dehydrated and he gave him IV fluid, kept him overnight, make sure he's doing fine and send him home. Next slide. So what happened was that this guy came back to emergency room again after a week and he had passed out again. So now what should we do here, right? So this doctor decided to explore more. And before I go into this patient case again, let's talk about this medical condition called syncope and loss of consciousness and see what can cause syncope. So next slide. Okay, so this is a definition I found somewhere. And what it says, sudden transient loss of consciousness and postural tone with subsequent spontaneous recovery. So the components are loss of consciousness, and it has to be transient, like brief loss of consciousness. Patient is not responding briefly. You call their name and they look like they're sleepy and not waking up. Postural tone, like the body goes limp, and then as a result of that, they fall, and then they recover spontaneously back to their normal self. And what is the cause of this? This has to do with blood supply to the brain. Briefly, the blood supply to the brain is inadequate or low, and because of that, patient passes out because you're staying awake or passing out or whatever is controlled by your nerves and the brain. So this is the definition as this component that patient loses consciousness, postural tone, but as a result fall, but recovers without any intervention spontaneously. And this is as a result of problem with the blood supply of blood perfusion to the brain. Many medical terminologies somehow comes from Greek words, and it has also Greek origin as you see it here. Next slide. So you see there is another definition here, a symptom complex composed of a sudden and transient loss of consciousness resulting from a temporary interruption of global cerebral perfusion. Same thing, but said in a little different way. This is, like I said, is a common condition which you may see in inpatient setting, outpatient setting, in emergency rooms. So this is not something uncommon. It accounts for 3% of emergency room visits and about 2 to 6% of hospital admissions or observation. So next slide. Having said that, let's see what can cause syncope. So the most common reason for syncope is what we call reflex mediated syncope. And most of the time it's not dangerous. So that is the good part. It's common, but it's not dangerous. Before we go into different type of reflex mediated syncope, I just want you to think about what is it that controls your blood pressure in the body, and what is responsible for perfusion to the brain. As you remember that the syncope happens because of the lack of perfusion to the brain. So we have to think what can interrupt perfusion to the brain. So you have this heart which beats and pumps blood into the circulation, right? So it has to pump normally to pump sufficient blood into the circulation so it can go to different organs, including your brain. And then you have blood vessels, which should be again normal so that the blood can go to the brain. If they constrict too much, then the blood pressure will go up. If they dilate, then the blood pressure will drop, right? So basically, this is really important for maintaining perfusion, that your heart and blood vessels are functioning normally. Heart is contracting in normal fashion, not going too fast or too low, and blood vessels are not too dilated or not too constricted, so that the normal amount of blood goes to the brain and your blood pressure stays in normal range. It's not too high or too low. Now, there are two more components for vein perfusion, which is your lungs, which supply oxygen, and that is carried through the blood to the heart, and then it goes to the brain. And other is nutrition, which comes from your GI tract, right? So just to keep it simple. Now, what maintains the heart rate and blood pressure? Next question is this. Okay, we are saying that your heart rate should be fine, your blood pressure should be fine if you want to have a normal blood pressure, normal perfusion to the brain. So that is where your autonomic nervous system come into play. This is a branch or part of nervous system which you are not aware of, but it controls many of your body function, including your heart and heart rate and your blood pressure. So it has two components, and I'm keeping it simple because it's not like a physiology lecture. So there is a sympathetic nervous system and parasympathetic nervous system. These are the branches of your autonomic nervous system. The function of sympathetic nervous system is that when it activated, it raises the blood pressure and raises the heart rate. Things go up. Parasympathetic does opposite, lowers the blood pressure, lowers the heart rate. Now, body maintains a balance of sympathetic and parasympathetic, so your heart rate does not go too up or too low. Same way, your blood pressure does not go up or too low. If this is disrupted for some reason, that can lead to low blood pressure and patient can pass out. Simple explanation would be like this. So reflex mediated syncope is as a result of that the body is not acting normally the way it should. If the blood pressure is low, the body should activate this way that the blood pressure goes up. Now in this situation, body is not doing that. So that is why it's called reflex mediated syncope. Now we will go to different categories of reflex mediated syncope. And the first one is orthostatic vasovagal. Look at the terminology. Orthostatic means that if you stand up, your blood pressure drops. Orthostatic. So if it drops abnormally as a result of gravity, blood pressure can drop too low and patient can become hypotensive in medical terminology. So second component is vasovagal. Vaso means blood vessels, so blood vessels dilate. Vagal is vagus nerve, which controls the heart, and it carries the parasympathetic fibers to the heart. So if vagus nerve gets stimulated, heart rate goes down. I told you that parasympathetic slows the heart rate. So vagus nerve carries the parasympathetic fibers and it slows the heart rate. So now you have a person whose blood pressure is low, and instead of blood pressure, your body, what body is doing, instead of raising the blood pressure, it's dilating the vessel, it's slowing the heart rate, so it goes further down, right? So it's an abnormal response of the body to a situation that results in low blood pressure and passing out episode. So this is what orthostatic vasovagal syncope means. It results usually as a result of prolonged standing. If you're standing for too long, particularly in warm environment, so that can be a trigger and people pass out. You might have seen, I've seen it in Pakistan. If you are traveling in overcrowded buses, it's hot weather, people can pass out from that because they are standing for a prolonged period of time and it's hot and they are sweaty, they're already losing water. And that is additional thing on top of that, and they pass out. So this is not like everybody will pass out in such situations. Some people are more prone to that, but this is not something dangerous. People recover, and if they are careful, they may not pass out again, and they do not need extensive testing and mostly these are younger people, not the older people. It's more common in younger, healthier people as compared to older people. The second category of reflex-mediated syncope is situational vasovagal. So the name tells you again, situation. So in this category, there is a stimulus which is causing the blood vessel to dilate, the heart rate to slow down inappropriately, and causing the drop in blood pressure and causing syncope. So what could be that trigger? Extreme fear, panic, pain, all these things can act as a trigger to stimulate this reflex and cause syncope. So this is another category of reflex-mediated syncope where body is not acting the way it should. Next slide. I think there is one in between. Yes. Okay. So there is another situation where you can have syncope, which is as a result of defecation and micturition reflex, or coughing, extreme coughing. Now your sympathetic nervous system is not just in heart, it also innervates other body organs. So if somebody has a strong desire to defecate and does not do that, sometimes that stimulates this reflex and they can pass out. And same is for micturition. So my advice is that don't delay too much. Okay, if you need to go, don't delay too much. But again, it's harmless. It does not cause any problem, except if somebody has syncope and fall, they can have injury, but syncope itself is not the dangerous type of syncope. I should say it is something which does not have long-term consequences in general. This carotid sinus syndrome does not, I didn't mark it right, it does not come under situational syncope. It's a different category. You have a carotid artery here in your neck, which supplies blood to the brain. And right here, there is a receptor called baroreceptor. So that baroreceptor sends signals to the brain and helps in controlling blood pressure. If somebody has this carotid sinus is acting more or is hypersensitive or whatever reason, and it get activated or does not act right, then it can lead to problem, right? So this carotid sinus hypersensitivity, people who have that, they can react to simple things like turning their head to one side might cause problem with this carotid sinus. Putting the tie too tight can push on the sinus, cause problem. And as a result of that, they can pass out. So this particular category in reflex-mediated syncope sometimes can have consequences because it happens more in older people. So this is one category where when you suspect this, you would like to make sure and refer it to cardiologists. So if anything else need to be done, that can be taken care of. Next slide. So this brings us to our next category of syncope, which is orthostatic hypotension. Now you will think I talked about this orthostatic under vasovagal also, right? But when I was talking about it, I said orthostatic vasovagal, which means the blood pressure dropped as a result of inappropriate response of the body. That's not what is happening here. The body is acting normally. The nervous system is not doing anything wrong, but the blood pressure dropped. Now, what would do that? I think we should talk about the second category first, which is volume loss. Because I think everybody's familiar with that. If somebody's bleeding, so what happens? Somebody's bleeding, too much blood is lost, they can drop their blood pressure. The body is going to try to compensate. The sympathetic nervous system will get activated to raise the blood pressure, raise the heart rate. But if somebody is bleeding too much, it may not be sufficient. So the blood pressure may not be maintained. Blood pressure will drop unless you pump blood into the patient or give fluid to the patient, the blood pressure will keep on dropping. Body has to have some balance, right? You cannot just rely on your nervous system. You need volume in the body also to maintain blood pressure. So here you are losing blood, you're losing volume, and if you don't replace it, the body may not be able to compensate for it too much if it is going on for too long or is excessive. And as a result of that, patient can pass out and even die if you don't intervene. The second volume loss category you see here is losing from GI tract, like as a result of nausea, as a result of vomiting. If somebody is vomiting too much, is having too much diarrhea, not able to take too much liquids, then what happens is that again, the volume balance is disturbed. The body is not getting enough volume. And as a result of that, body cannot compensate just by activating your sympathetic nervous system, and the blood pressure will drop. The third category here is decreased thirst in old people. Like as you grow older, you may not realize that you need to drink water. Normally, if you are behind fluids or you're getting dehydrated, body tells you, you get thirsty, go and drink water, right? So in older people, sometimes they have decreased thirst. And in some older people, if they are living alone, like that happens in USA commonly, and they are not very functional, they may find it hard to go and get the water. So that can be a factor also. And so because of the lack of water, lack of volume, their blood pressure can drop. So this is orthostatic hypotension, categories volume loss, where you're losing the fluid or not getting enough fluid in your body to maintain blood pressure. But the body's nervous system is acting in a normal way, and that is not contributing to it. The second category here is medication related. Now, people take blood pressure medicines, and many of them, what do they do? Because the blood pressure is high, many of them work on the blood pressure, dilate them, or work on the heart, basically, so that the blood pressure does not go too high. So the medicine that dilate the blood vessel, that is how they act. They are interfering in body's normal defense mechanisms, right? So if you give too many of those medicines, or sometime even with some normal doses also, patient can draw blood pressure on standing, and if it is excessive, can pass out. Second category of medicine here is diuretics. So what do diuretics do? These are another category of medicines which are used to control blood pressure, and sometimes they are used in people who have too much fluid accumulated, like their legs are swollen or they have fluid in the lung as a result of congestive heart failure. So you give them these diuretics to get rid of this excessive fluid. Okay, so if you do too much of diuresis, then again, the volume balance is disturbed, and as a result of that, patient get dehydrated and pass out. So this is how it can happen as a result of, can we go backward? There's one more category there. One more category there is, I'm sorry, is autonomic failure. Now, your autonomic nervous system, if there is a disease process which is directly involving the autonomic nervous system, that can affecting the autonomic nervous system, that can also result in to orthostatic hypotension. And examples of diseases are spinal cord injuries can disrupt the autonomic nervous system, diabetes, Parkinson's. There are many other conditions. I haven't listed everything, but just to give you an idea that can be another category where patient can pass out because of the drop in blood pressure. Next slide. Cardiac syncope. Now, this is the serious stuff. Basically, cardiac syncope is something you never want to miss. And the first group that I talked about, vasovagal syncope, in general, patients do have some symptoms before they pass out, like they might get dizzy, they might get lightheaded, they might be sweaty, they might be pale, they might notice themselves their heart rate is slow. But cardiac syncope many times comes without warning. Patient does not know that he's going to pass out and he may suddenly pass out. So if somebody's passing out suddenly without warning sign, that is more concerning as compared to a patient who passes out and tells you that, you know what, I've been feeling dizzy for many days, or before I passed out, this is what I felt. Now, medicine, I think, is an absolute rule, but in general, a cardiac syncope, you may not experience any symptom, and in general, with vasovagal or hypotension, you will before passing out. Cardiac syncope can result, I have put 3 categories here, as a result of heart rate going too fast, which is tachyarrhythmia, as a result of heart rate going too slow, which is bradyarrhythmia, and structural heart disease, which is some problem with the heart itself. Now, tachyarrhythmia, normally the heart rate is between, they say 60 to 100. It may go to 50 also. It does not, you don't pass out. Similarly, you don't pass out if it goes to 110, 120, you're running, your heart rate goes up many times above 100. No, not this much of increase in heart rate. It has to be really excessive increase in heart rate or excessive decrease in heart rate that can make a person pass out. So for tachyarrhythmia, for example, if somebody's heart is beating in like 200 and 300 per minute, that's too much. The heart is going like this, and so it cannot pump blood effectively into the circulation. And that is where brain will have inadequate perfusion and patient will pass out. For bradyarrhythmia, now the heart is beating too slow, like 20 per minute. It's going like this. Again, because it's too slow, it's not pumping enough blood into the circulation. And as a result of that, brain is not perfused adequately and patient can pass out. Example of tachyarrhythmia is one example is ventricular tachycardia, or I mean, if we can have a separate lecture on tachycardias and bradycardias also. But basically, tachycardias can originate either in the upper part of your heart or lower part. Upper is atria, and lower is ventricle. You have 2 atria and 2 ventricles. So for simplicity purpose, if it comes from atria, it's called atrial tachycardia. If it comes from ventricle, ventricular tachycardia. In general, ventricular tachycardia can be more dangerous, although atrial tachycardia can also cause syncopal episode. Now, coming to bradycardias, what slows the heart rate in general, it's some kind of a block in the heart. So normally your heart electrical power lies on the right side of the heart, on the upper chamber, which is your right atrium. And then it goes down to the ventricle. So from atrium to ventricles. And there is in between something called AV node. So if that thing is disrupted or there is a block, then what happens is that the heart cannot beat as strongly as it should. And the heart rate drops too low, and that is why you call it a heart block, and patient can pass out as a result of that. Structural heart disease, something is not right with the heart itself. Now, there are so many conditions which can fall into this category that heart is not normal, but I didn't list it here, but I should mention that heart attack. If somebody's circulation to the heart is blocked, that can result into heart attack. And if this is something like a big blood clot going into the blood vessel of the heart, then the heart can not function properly and patient can just pass out as a result of heart attack. The other category I have mentioned here is aortic stenosis. Now, I wanted to put a slide, but somehow I apologize. I didn't have sufficient time to do that. So, but I think that most of you know that heart has 4 chambers. right, like I mentioned before, right atrium and right ventricle, which is the right side of the heart. And then you have left atrium and left ventricle, which is the left side of the heart. The right side of the heart collect all the blood from the body, and then it pumps it into the lung to get all the oxygen. And then it goes into the left side of the heart, and it comes through the aortic valve into the big vessel called aorta, and then it goes to rest of the body. So this aortic valve sits right where the blood is being pushed into the circulation from the heart between the left ventricle and the aorta. Stenosis, if it gets tight, what would happen? Now, the heart is trying to pump blood into the circulation, but this is all narrowed down where, and so the blood cannot go into aorta the way it should. And because of the insufficient blood going into the aorta, if that person exercises or do something, he may pass out. Hypertrophic cardiomyopathy is something a little similar to, I should say, aortic stenosis. The only difference is that now the narrowing is a little below the aortic valve. In the left ventricle itself, there is muscle is much bigger than it should be and causes narrowing when the heart contracts and sufficient blood cannot go out. So the problem with aortic stenosis and hypertrophic cardiomyopathy is that the sufficient blood is not going into the aorta because of the blockage, and that is why there is less perfusion to the brain and patient can pass out. Cardiac tamponade. Cardiac tamponade is that your heart has a lining. If something accumulates in the lining, particularly blood or fluid or something, then any type of fluid, then it is going to compress the heart. If it is an excessive amount of blood, it will compress the heart. That is what cardiac tamponade is, that your heart is being pushed from the outside. There is this lining outside your heart which has accumulated this fluid, and now it's pushing on the heart and does not let the heart function. So the person passes out again. And there are many more categories, but just remember that in the cardiac syncope, it can be a heartbeat function problem or problem in the heart itself that can lead to syncope. Next slide. Okay, so now we come to another group of condition which can cause syncope, which is your lungs. Your lungs oxygenate blood, right? So lungs also have blood supply. And if there is a clot that forms goes to the blood vessel in the lung, that will compromise function of the lung. So the lung will not be able to oxygenate blood the way it should. And if it is a big blood clot, it can actually compromise it this much that patient can pass out. And then vascular category, I talked to you about aorta. Aorta is the big vessel that carries blood from the heart, and then it divides into different branches to supply blood to the brain and other body organs. So if this big blood vessel has a problem, then again, there will be problem with perfusion. One problem is dissection. What happens is that the blood vessel has a wall. So if the blood, instead of staying in the lumen of the wall, starts going into the blood vessel wall, then what happens is that it would again compress the actual blood vessel and cause problem with the circulation. This is what the slide I wanted to include it because I thought it would be difficult for me to explain it to you. But inshallah, I'll do it next time. Because I am planning to do a follow-up lecture on syncope to go into more detail, and then we can talk about it again. This is more like, this time I'm just giving you an overview. So next slide. Okay, So now we were talking about syncope, but then there are conditions which can look like syncope. Okay, so you have a job to differentiate those conditions as well. That is it syncope or is it something else? Seizure. Seizure is a very common condition that you have to think about, okay? That is it a syncope or seizure? But in general, if somebody has a seizure, instead of, in addition to passing out, they also start shaking. So that is one thing you want to know, that well, sometimes with syncope patient can shake too, but for the sake of simplicity, seizure in general, they have this episode where they pass out, but they are also shaking. And when they wake up, they are not back to normal right away, unlike syncope. They might stay drowsy for some time. So these are the differentiating point. And they can also bite their tongue or lose control over the urine. So those are the clues that you can have. Okay, this is not syncope, it could be seizure, that the person was shaking, he bit his tongue, he lost control over urine, and when he woke up, he wasn't back to normal, he was drowsy for some time. So this, but again, you have to do tests to confirm whatever suspicion you have. Pseudo seizures are not actual seizures. It is like something where patient, it seems like that patient is having seizure, but actually it's not something which is originating in the some abnormality. For the definition of seizure, you should have something abnormal in the brain causing abnormal electrical discharge so that the patient has a seizure. In this condition, pseudo seizure, that's not happening. That abnormal discharge is not happening in the brain, but patient looks like as if he's passing out. It's really difficult to diagnose, and most of the time you have to involve them. They have to go through multiple tests to differentiate between seizures and pseudo seizures. Accidental fall. Sometimes older people, they may have dementia, they fall, they were alone, they may not remember. Did they pass out or they did not pass out, right? So they may not have passed out, but you don't know. So sometimes that can be something you have to think about syncope. Somebody came with fall and you don't know whether he passed out or he didn't. So one more category is the stroke or TIA, vertebrobasilar. Now, the posterior part of the brain, which controls the brainstem, if that part is affected by the stroke or mini stroke, that is something which can cause hypotension and patient can pass out. So that is another category you should be aware of. And then any metabolic disturbance like low glucose, electrolytes can also affect the function of the brain. And it may seem to you that this patient might have passed out, but actually it's as a result of these conditions. And again, oxygen, low oxygen and high carbon oxide level in the blood, which is from another group of conditions, can also look like as if patient does not have enough awareness or is not responding to you, but it is not exactly a syncope. It's more like as a result of low oxygen and high CO2 level in the blood. Intoxications are another category which you have to think about, like alcohol, drugs, that may appear as if patient has passed out. So if patient has passed out, your job is not only just to think about conditions which can cause syncope, but also other conditions which looks like syncope, like seizure, pseudo seizure, like I mentioned here, stroke, falls, electrolyte abnormalities, glucose abnormalities, low oxygen, high CO2. And so that is why you need blood tests to check for metabolic abnormalities. For glucose, you check their oxygen level. If somebody has a drinking history or drug level, you check for those things also. And if you suspect seizure and you think it may not be syncope, then you do some tests to see that if it is seizure or if it isn't. So let's go to next slide. I hope I didn't make it too complicated. I try to keep it simple. So we are back to our patient. now you had this background information about syncope and what causes syncope. So now let's talk about this patient again. So this doctor who saw the patient said that I need more information from this patient. Why is he coming again and again to the ER for syncope? This is his second visit. So he learned that actually this is not the second visit. He has passed out before also. And he also learned that patient had a surgery because he was really, really heavy or overweight, had morbid obesity, in other words. And he did this surgery to reduce his weight, and he did lose a lot of weight, like 100 pounds, from 300 to 200. And after his surgery, after some time, he started having this syncopal episode. So there was some link with the weight loss. And then he was taking these antihypertensive medications, 4 of them, and they were stopped and restarted many times. So that was another hint for the doctor, and he tried to look through his records, and he found that some doctors realized that this patient has lost too much weight and he does not need this many medicine. And they took him off most of his blood pressure medicine, leaving just one. But then when he went to the hospital, the doctor who was there was in a hurry, did not realize that some of his medicines have been stopped. He looked into the computer, 4 medicines were showing up. He assumed that these are his medicines, and when he discharged him, he started all those medicines all over again. So then he came back again with syncope. So this is something happened in this particular patient's case, that he had lost weight. He wasn't requiring that many medicines, but since the doctors did not look back to his records, they restarted his blood pressure medicines again and again, different doctors. And he passed out again and again, and he was himself confused. He wasn't a physician. He did not know whether he should take 3 medicine, 4, 2, or 1. So that is where the problem was. Can you go to next slide? So I just want to emphasize by describing this case that patient is there actually to tell you the story. He wants you to listen to him, and he will tell you everything that he had, what has happened to him. If you listen to the patient, you will not miss the diagnosis. Like in this particular patient, the first physician was in a hurry and did not listen to the patient, but the second did. So listening to the patient is very important. If you know 101 tests to diagnose syncope, they are not going to help you if you did not listen to the patient. First step in medicine is always to listen to the patient and get a detailed history, detailed information, so that you know what exactly patient is doing in his life, what is happening, and what factors could have played a role in his disease process, not just syncope, any disease. If you don't listen to the patient, you just rely on blood tests and x-rays, you will miss many diagnoses. I should say you make your impression listening to the patient what it could be. You would have 4 or 5 conditions in your mind that those are more likely. So when you're ordering tests and you're checking on the patient, you're actually confirming your suspicion. So if you did not do the first step, you're already not in the right direction. So pay attention, listen to the patient, listen to his story, listen to the sequence of events that happened. What happened first, what happened second, what happened after that, and that would help you in reaching the right conclusion. The second lesson of this case is that do not forget medicines. Now, I've seen many physicians do not like to go through the medication reconciliation, but I would encourage you, as a physician, you should always do medication reconciliation. Because if your patient comes to you and you put him on medicine which he is no longer taking, you are not causing any benefit to the patient. You actually can make patients sick. So you should be aware which medicine patient is currently taking. That should be your starting point. And then you can guide the patient that you need to increase the medicine, you stop, decrease. So don't forget to review the medicines that patient is taking, because this is one crucial step some people don't pay attention to. And third is that syncope, although it's common, it can happen frequently. It may not be dangerous in most of the situations, but it can be life-threatening in certain situations, particularly cardiac syncope, where people pass out without warning. So if you think it can be something like that, do proper workup. Make sure that you do tests that would help you in reaching the diagnosis. Briefly, if you're thinking about structural heart disease, you should get an echocardiogram. You don't need to do it on every patient. If you're thinking that this patient might have an arrhythmia, in general, patient, when they're kept for observation for syncope, they are attached to telemetry, which is like you are monitoring their heart rhythm and checking if their heart rate is going too fast or too low. But sometimes that is not sufficient. And if you think strongly and patient is passing out again and again, it's your responsibility to refer that patient to the cardiologist so he can have more detailed testing to find out if there is any problem with this patient's heart. Also remember, such thing happens more commonly in people who are older. Older people are more likely to have more serious causes of people than younger people. That does not mean that younger people cannot have serious problems, because like I mentioned, hypertrophic cardiomyopathy can be in younger person also, but usually they would have on examination a heart murmur or some abnormality or EKG that you might be able to see. So if you're not sure, refer the patient to a specialist. And as a starting point, always listen to the patient. And if you have doubt in your mind, consult somebody. So thank you. That is the end of my presentation. And we will discuss more about syncope treatment and diagnosis in the next lecture.
Thank you very much for your mentorship and teaching, Dr. Khan. I know I really learned a lot. And if anyone has any questions, they can feel free to ask now, and we'll now begin our Q&A session. So our first question is, how would you describe your day-to-day work as a nocturnist?
Okay, so as a nocturnist, people can work in different settings, and some hospitals have 7 days on, 7 days off, others have flexible schedule. But I chose to work 3 days a week. And so I just wanted some regular schedule and some normalcy to my life. So I work Sunday, Mondays, and Tuesdays, and I work 12-hour shifts. And basically, I should say I'm mostly in the ER. And any patient that need to stay in the hospital, the ER doctors contact us. They give us the information, what tests they have done so far. And from there, we take over. And again, I would like to emphasize that ER doctors, their job is different. They may not sit with the patient to get the detailed history. It's your job as an internal medicine doctor. And so if the ER doctor has missed anything, you should be able to pick it up. So basically, that is part of your job. So you do detailed history, a physical exam, you make a treatment plan for the patient. You also decide whether this patient can stay for a shorter period, which in America, because for insurance purposes in USA, it's called an observation stay. And you also decide if this patient needs to stay longer, which is like admission. Besides that, at nighttime, if any patient who is already in the hospital is having any issue, you go and check on those patients and treat them and address their situation. So this is basically wherever you need help, you should call a subspecialist. Subspecialist, majority of the hospital, you do have critical care doctors in-house. You do have surgeons in-house, but you don't have all the specialists in-house. So whenever you're in facing an issue or somebody's critical, you do ask critical care doctor to assist you. So this is how you most of the time work at night.
Thank you for your answer. And now the next question is, how do you manage not having all specialists on board, but on call? And how did you develop the skills to know when you need to call in a specialty?
Okay, so basically, I think you should be neither overconfident or not or underconfident, right? So, and basically, if you stay focused, that what I've seen that people would call specialists more if they have this fear of lawsuit, right? So they think, okay, if I didn't call a specialist, I may land up into lawsuit. I think that's not the right way of practicing. So what you have to do is you should think, what I am doing, am I confident that what I'm doing is the correct thing for the patient? And if you feel that you lack knowledge in that particular area or you need somebody's opinion, that is where you should ask for consultation. So some people make unnecessary calls if they are underconfident or they are worried about loss. So for example, if somebody is admitted for heart attack, and I mentioned the test troponin, which is to look for the heart attack. Now this patient, you already know that has a heart attack. He's fine. He's not having any pain. The cardiologist already knows about the patient. He will go for heart catheterization. It's already scheduled. But the troponin is being monitored in the hospital, and nurse tells you that this is the number abnormal. You don't need to call the cardiologist. You already know that this patient has a heart attack, right? But if you feel, no, I have to call the cardiologist because I want this doctor to know in the middle of the night that this is a wrong number, on which he's not going to take any action, that is an inappropriate call. So also you have your colleagues. There is no harm in discussing your fellow nocturnists if you have any doubt that, what do you think? And sometimes that helps you and relieves your concern that, okay, what I'm doing is right, because it has happened. And over the years, you slowly develop that skill and experience that, okay, this is something I can handle on my own, and this is where I should call a subspecialist. But again, I would say, whenever in doubt, it's better to call the specialist. If you feel I'm not sure, just call somebody to help you.
Thank you. Our next question is, given your credentials as an FACP, how does it benefit you having that credential as a physician?
Okay, so FACP is Fellow of American College of Physicians. American College of Physicians is one organization that basically very prestigious, and if you become member of the organization and work for them, they have you can be just member. When you initially, you don't need anything to do to become a member. So basically, if you want to be a fellow, you should be either involved in research or you participate in activities for ACP to benefit other physicians. And there are different tracks. So you work on those, and that is where you become a fellow of American College of Physicians. So I should say just an honor to be a fellow of American College of Physicians. Otherwise, people think that you're somebody who's dedicated to your profession.
Thank you. Our next question is, given your previous experience, how difficult is it studying medicine overseas and then doing a residency in the US as an IMG versus directly studying medicine in the US?
Okay, so for studying in Pakistan, and what I feel, because my son is doing medicine here, so it is structured differently, and I'm sure other countries might have different structure, but because they do not have that many tests available in every place, so resource limitations, so they train you very well in history taking and in physical exams, so that you are less reliant on the tests, right? So that is one strong part of training in Pakistan, I should say. And I do not know about maybe other developed countries have same strength, but you're not exposed to certain things like, for example, if you're trained in Pakistan, you may not see many such complicated cases that you see in USA, and you don't learn to treat those cases very well, except in certain places. So that is the limitation. And also sometimes you need the test to make a diagnosis, and it might be difficult for you to do that. So working in USA, I felt that I have all the resources available. But the difference is the training here is that I think at this point in time, what I learned from my son is that in medical school, you spend 2 years. In Pakistan, we have a different structure. We do 12th grade and then we do 5 years of medical training. We don't do bachelor's degree. But in USA, you do a bachelor's degree, you pass the exam, and then you go into medical school for 4 years. So the first 2 years are more like studying for different medical conditions. And basically, at this point, many programs are shifting towards problem-based learning, what I heard. So basically, they are teaching many subjects together for to learn one diagnosis. And after 2 years, students start rotating in different places, and that could be not there, could not be the same hospital where you were, where your medical school is situated. That does not happen in Pakistan. Your hospital is attached to the medical school. You go and get training from that hospital. So those are the basic differences. That basically the program here requires a bachelor's degree, doesn't over there. The medicine program is longer over there, 5 years with more emphasis on basics. And here it's shorter, but you have more, I should say, opportunity to see more advanced imaging techniques and stuff like that. And the third difference, like I mentioned, that you are studying in Pakistan in the same hospital, but here you go from one place to another. So it's difficult to say what is better, but I think there are certain strengths to what I was in Pakistan, what I learned in Pakistan, and certain strengths here. So, but definitely residency training programs are excellent in USA.
Thank you, Dr. Khan. I'll now pass it off to Hamza to finish our Q&A.
Thank you, Dr. Khan. My name is Hamza, and I'm currently pursuing a joint BSDO program at the Lake Erie College of Osteopathic Medicine in Pennsylvania.
Okay.
For the rest of our questions, I'll begin with this. Given your active community involvement, why is it important to give back to your community?
Okay, so basically, when I was a medical student, that starts like in Pakistan again. So we had many patients who were coming to the hospital and could not afford care. And so we were a group of physicians, and we thought, that's not right. We should try to do something to help them. So we made an organization called Patient Welfare Society. And so that is where my journey started to this kind of work. And so basically what we were doing is that we were trying to collect money for them to give them medicines. If they did not get the right blood, then we kind of donated blood ourselves also. So those kind of things. But coming here, I initially did not realize that in USA also, I thought it's a rich country. We don't need to do those kind of things here. But over the time, I realized that there are people who are facing hardships here. And as a community member, we should try to help the disadvantaged members of our society. So that is where I got involved in this type of work, because I feel that it is your duty to not just to treat the patients, but to look for the general well-being of your community also, so that they don't get sick, they don't land up in the hospitals. and you are kind of giving a positive contribution in their life. So we have, during this pandemic, I work for an organization called Association of Pakistani Physicians in North America. So the last 2 years, during this pandemic, we did a lot of work distributing food, and which is like we collected money ourselves. We helped hospital getting personal protective equipment. We tried to raise carried out blood donation. So different types of work. Basically, we felt it's our duty as a community member to give back to the community. And I am of this mindset, like my fellow colleagues.
Thank you for that question. Thank you for your service to the community through UPNA. That's the first thing I'd like to say. And our last question will be this. What do you believe are some of the best ways students can learn more about pursuing internal medicine?
What are the best ways to learn about the internal medicine?
Yeah, what are the best ways students can learn more about pursuing internal medicine?
Okay, so like if you want to pursue career in internal medicine, there are different ways, like basically interacting with the doctors, like doing observation with the physician office, and that gives you an insight how does an outpatient physician works. Working in a rehab center and seeing what exactly happens in the rehab center. You can work in the hospital, shadow with the doctors and see what exactly they do, and do you like to do that. So I think that is besides looking over the internet, talking to your colleague, going into the office setting, going into the hospital setting, seeing or observing a physician, what exactly their work is like, would also help you in making your decision in pursuing medicine. And most of the people in US, they do that actually before they apply for medical school. I do not know if they do that in other countries, but in USA, I do know that all the students who join medical school, they do explore, they do see what is the life of a doctor is, and they try to get firsthand knowledge from the doctors. So besides looking on the internet and asking your friends, and that's what you do.
Thank you very much, Dr. Khan. We truly appreciate you taking the time to answer all of our questions. This was a greatly informative session for all of us. I'd love everyone to please give a warm thank you to Dr. Khan, our TeleShadowing Medical Director, in the chat box for this incredibly informative session, and thank you.
Thank you.
If you'd like to learn more about our team, feel free to check out our website linked in the chat, teleshadowing.com/about-us/our team.
Okay, thank you.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for this session is now live. You'll need a 70% or higher to pass and receive certification. The link to the quiz is currently going to be put into our chat. Many of our students have expressed interest in pursuing our leadership positions in teleshadowing. We have reopened our leadership application as we strongly believe in extending opportunities to others, and that link will also be put into the chat. Don't forget to join our mailing list if you haven't already, as we send sessions and quiz reminders right to your mailbox. You can join from the link in the chat right now as well. And now finally, on to our future session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all in the next session next Saturday on December 11th at 10 a.m. Eastern Time, with a physician mentoring us in pathology. We will not have, my bad. Thank you so much, everyone, for attending today's session. We hope to see you in upcoming sessions. This includes this week's shadowing session.